Hello viewers, welcome to my channel. A patient presented with severe sore throat. On pharyngeal examination, we found everything okay. Then on X-ray lateral view, there was a specific sign which indicated that it was a case of acute epiglottitis. Today I am going to talk about acute epiglottitis. First, what is acute epiglottitis? It is an acute inflammatory condition of the supraglottic structures like epiglottis, aryepiglottic fold and arytenoid. There is marked edema of these structures which causes airway obstruction. It typically affects children of 3 to 6 years, but it can also affect adults, and it is more common during spring and winter. As the definition says that in epiglottitis, supraglottic structures are involved, so acute epiglottitis is also known as supraglottic laryngitis or supraglottitis. Haemophilus influenzae type B is the most common organism responsible for acute epiglottitis in children. But in adult, the organism is different. Here the organism is group A beta hemolytic streptococcus. In immunocompromised individuals, atypical organisms may be involved like Streptococcus pneumoniae and Candida albicans. Now come to the clinical features. The onset is very abrupt with rapid progression. Sore throat and dysphagia are common presenting symptoms in adult, but dyspnea and stridor are common symptoms in case of children. Muffled voice and drooling may be seen due to odynophagia and dysphagia. There is fever which may be up to 40 degrees Celsius. It is due to septicemia. The child is very toxic. Traditionally, the child will be sitting upright with neck extended to optimize the airway and using his arms to support the shoulder girdle. This is to maximize the efficiency of the accessory muscles of respiration. This upright sitting position with extension of the neck to optimize the airway is known as tripod sign. Now come to the examination and investigation findings. On depressing the tongue with tongue depressor, we may see the epiglottis is red, swollen and inflamed and obscuring the view of the laryngeal inlet. This appearance is called red cherry epiglottis. Along with red swollen epiglottis, pooling of saliva is also seen around the epiglottis. But this pharyngeal examination is not well tolerated in children, so it is contraindicated in children, and if it is to be done, then it should be done in operation theatre with all preparation for intubation or tracheostomy. But the adult patient can tolerate this pharyngeal examination. We can do X-ray soft tissue neck lateral view. Now have a look at an X-ray. Look, the epiglottis is very swollen and it looks like thumb finger. This thumb finger like swollen epiglottis is known as thumb sign or thumb print sign. When the epiglottis is swollen, then there is no well-defined vallecula. This is known as vallecular sign, that is absence of deep well-defined vallecula. So what is the treatment? Acute epiglottitis may be very fatal, so the patient must be hospitalized on emergency basis. First, the airway must be secured with endotracheal intubation or tracheostomy. Endotracheal intubation is preferred nowadays, but when facilities are not available, then tracheostomy may be opted. After securing the airway, we can send throat swab for culture and sensitivity. We have to start ampicillin or third generation cephalosporin in injectable form without waiting for the culture sensitivity report of the throat swab. Steroids like hydrocortisone or dexamethasone is also initiated. Adequate hydration should be maintained with parenteral fluid. The patient may require humidified oxygen supplementation. Sometimes a mixture called Heliox is used. In Heliox, there is 21% oxygen and 79% helium. Heliox has lighter gaseous density than oxygen, which allows its easy flow through the narrowed airway. We can give nebulized adrenaline to the patient. The adrenaline causes vasoconstriction and causes rapid relief of edema of the epiglottitis. But as soon the adrenergic effect is gone, then the mucosa again becomes inflamed and edematous, which is called bound effect. So it is only a temporary measure. We have to secure the airway when we are using nebulized adrenaline for temporary relief. So what is the prognosis of acute epiglottitis? As I have mentioned that it is very fatal if proper treatment is not initiated. But if proper treatment is initiated, then thankfully it is very responsive to treatment and extubation can be done within 48 to 72 hours. So how can we prevent epiglottitis? First one is the Haemophilus influenzae type B vaccination. The incidence of acute epiglottitis has been dramatically decreased by 90% after initiation of Haemophilus influenzae type B vaccination. It is now occurring in unvaccinated child and in case of vaccine failure and by some other organisms. And as the organism of adult epiglottitis is different, adult epiglottitis is also seen. And second one is rifampicin therapy. If household contacts of Haemophilus influenzae epiglottitis include an unvaccinated child under the age of 4, then all the family members, including the patient, should receive prophylactic rifampicin for 4 days to eradicate the carriage of Haemophilus influenzae. In the end, in children, acute epiglottitis may be confused with acute laryngotracheal bronchitis or croup. In case of acute epiglottitis, dyspnea or respiratory distress is the main presenting feature. But in case of croup, barking cough is the main presenting feature. That's all for today. Thanks for watching. Goodbye.